to everybody else. We are pleased this morning to have all of you on board. Karibu sana. As the country experiences the third wave of coronavirus and people are worried, APA Insurance found it good to have Daktari online so that he can help us address some issues that have had challenges and others that we are anticipating and whichever worries we have. So you're welcomed this morning. We are honored to have you. Feel free to send your questions on the chat and even feel free to send it on the Q&A. And I have an able team with me today who will be helping me up. So without much of your time, I would like to welcome Dr. Moses Muya Masika. Dr. Moses is a virologist at the University of Nairobi. He's also in charge of the Department of Microbiology and School of Medicine. And he's also involved in a lot of research at the university. So this morning we are honored to have you, Dr. Masika, and I would like to welcome on board Karibu Sana, Daktari.
Thank you so much for the colorful introduction. Just like to correct that I'm not the boss of my department. I am a servant, and I spend most of my time teaching virology, doing research on viruses, and sometimes consulting on the same. So I'm also grateful for the opportunity to discuss COVID-19 being quite a topical issue today in our lives, and I hope that everyone in the presentation or in this Zoom will feel free to engage either through the chat or whenever you open the session for questions. I'm open to any questions and any discussions, and we can have this to learn from each other. So can I start now? Or do you have something else to say?
No, Daktari, I'm sure our participants are eager, so I'll just allow you to kick it off, Daktari.
Thank you very much. So today I will focus our talk on variants and vaccines because this has been what is on many of our minds and lips, but not to forget the basics that really what affects us when the rubber meets the ground. So this is the outline of what we will discuss today. Status report, basically looking at the numbers. Signs and symptoms, I put this here because we have seen some discussions on the new variants and maybe new symptoms. So I'm going to put that to rest. I will also highlight elements of management to basically summarize what the scientific consensus is currently on management. And also variants, it's a huge topic to discuss that I'll summarize it in a few slides, and the vaccines, and propose a way forward that I think all of us can take part in. So you may already know that our global number of cases are way above 120 million, which is quite a number considering a year ago there were only a handful in very few parts of the world. And we see that Africa has perhaps somehow been spared or has reported much fewer cases than we expected. That is still debatable why it is so. And Kenya, although we could have had worse numbers, we have about 115,000. If you notice, I put in round numbers because I find it easier for people to chew than putting the exact numbers. For example, our deaths in Kenya, I think 1,937, but I just rounded it off to 2,000. So it's easier for me to discuss it this way. But across the globe, we've lost 2.7 million people, which is a huge chunk. If you think about, there are very few diseases that have managed to do that in a year. Maybe just the cardiovascular diseases put together. So the picture in the world is really, in terms of mortality, is really the same, although in some places it goes high. So losing about between 1 and 3 people in every 1,000 with COVID. So that has been in every 100 with COVID, sorry, not 1,000. So that has been the trend in most people and in places, unless there is a very huge surge that the hospitals are overwhelmed, so they cannot take care of patients. And when that happens, then you end up having higher mortality because people would have gotten better care, cannot access it. You've also heard about the third wave in the country. Let me see if I can hide this thing. But anyway, so this curve or this chart is showing a 7-day average. So if you take every day, every average for every week, the average for every week in Kenya from March, you can see we had our first surge in August. We did take serious measures, and by September we started seeing cases going actually very low. And I remember this time talking to some people in the counties, and they were asking, really, did we build all these hospitals for nothing? Did we spend our money for nothing? But quickly thereafter, we actually now had the second wave, which now spread outside Nairobi and Mombasa, where the previous wave had been confined to. And we ended up with very high numbers in November. And you remember before this, there was a lot of political activity, people relaxing and all that. And during in December, we saw another drop. We think there was a minor spike after Christmas, but it wasn't so pronounced. But now we are now seeing the third wave. And it's not really a systematic thing that you must have one wave or two waves or three waves or four waves. It's really what we've seen in the past, that if you follow the laid down prevention measures, you control COVID, because most of these do not need a lot of money. They cost the economy a lot, because by social distancing, by avoiding crowded places, the economy is suffering. But the individual need not pay so much out of their pocket. You do not need to pay so much now for a mask like we did initially. You do not need to pay so much for social distancing, although sometimes, of course, it may mean for some people staying away from some of the works that they do, which is costly as well. And washing hands is now not so expensive, and it's not as hard as many of us believed before. So there are measures that we've seen working, and every time we drop them by engaging in crowds, either as family gatherings or political gatherings, which we've seen in many forms, from funerals to roadside impromptu meetings, we see the virus strike again, and it creeps in slowly, because transmission doesn't occur overnight. One person will infect maybe 2 to 3 people in 5 days. In another 10 days, we have 5-6 people infected from that original one person. In another 15 days, you have another 12 or so, 18 people infected. So it is creeping on us slowly, and before we know it, the wave has picked momentum, and we have to invest much more to contain it than if we had maintained the prevention measures when it was down. So that is really about the waves we are seeing. And some countries have actually just had one wave, others have had two, others are still seeing an increase. The signs and symptoms, I think I need to find a way to hide my, I think. So the signs and symptoms, I've classified them into 3. One are the common ones that most people tend to report, and these are fever and cough and fatigue. But you also have less common ones. I'm sure you've heard of people reporting things like loss of taste or change in taste, loss of smell. A few people have a runny nose, have sore throat, and what have you. These are reported and different by different people. But what I would like to highlight is that one of the things, especially for people who are staying at home, is we have some people who are wondering, at what point do I go to hospital? Because you've been told to stay at home, and especially if you're the caretaker, you are afraid and some very anxious at times that the person you're taking care of does not die in your hands. And that is really natural, because it's somebody you love. And so people are asking, how do we know when to go to hospital if you are on home-based care? And really, one of the things that you need to watch out for is difficulty in breathing. We are not able to do pulse oximetry or taking oxygen levels in the house for many people. If that is possible, it helps to check whether this is really oxygen or breathing is a problem. Persistent chest pain, which is sometimes due to anxiety, but if it is there, it is worth checking out. Confusion, because it means you're losing consciousness, and maybe because the brain is not getting enough oxygen, or because you're actually getting quite sick. And cyanosis, it presents differently. In some of us who are very dark, it may just be grayness or nothing at all. For those who are a bit lighter or yellow, you'll be probably turning blue and other colors that are not normal. Eventually, people may lose consciousness, and hopefully we don't get there. Sometimes, of course, there's a quick turn of events, especially if the oxygen levels have been dropping and no one noticed because they drop gradually. And that's why pulse oximetry or taking the finger oxygen is useful for those who are doing home-based care. So when you see any of these symptoms, then you need to go to hospital as soon as possible. So for those who are home-based care, are advised to make sure they have a plan so that if something happens and they need to go to hospital, you already know where you're going and how to get there. Now, there was a discussion a while back with some charts showing that the new variants cause this or the other and not this or the other. Really, there's no difference. The symptoms are the same. What we are seeing is the frequency. So for some people, for one variant, the original variant, we see you're more likely to report cough than the original variant, although we still report cough for both strains. And so the symptoms are the same. It's just that some are more frequent in the variant or less frequent in the variants. And this was based on the data in the UK. So we don't have any local data in Kenya, unfortunately, to support this, although we've seen doctors reporting that they are having an increase in numbers. I haven't seen any report for new symptoms as such. It's just that some of the symptoms have become more frequent and others have become less frequent, which is okay. So with this kind of presentation or symptoms, how do we manage people with COVID? One is to recognize that most people, a majority of people will have mild disease, another great majority will not have symptoms, but those who have mild disease will do well on home-based care. These are the people with fever, fatigue, a cough, but they're okay. And the reason for home-based care is to reduce interaction with other people, some form of isolation really, but also to be observed and monitored closely so that if something changes, they can be taken to hospital as soon as possible. This is contrasted with the people who may suffer severe disease, and these are the people who develop difficulties in breathing, especially that, but may not necessarily require ICU care. So this would be sufficient with oxygen supplementation. And I think the minister touched on this yesterday or the day before, I can't remember very well, that there are people who may require to be given oxygen but at home because the beds are now full. So this may be the category that will either live or die depending on the care we give them. Because if we don't take care of them at this stage very well, then they could tip over to the last category of critical condition. And these are the people who will not survive unless they get an ICU with mechanical ventilation and basically you're breathing for them, giving them oxygen, supporting their organs and looking at their vitals or their monitoring their vitals very frequently. Unfortunately, this is a smaller number. And what usually changes the mortality is the second group, where if you're not able to take good care of them, they will end up in the third group. Sometimes that means lost life that could have been prevented. So what are the treatments options? I think this is very basic. There are many other things that you could do, but really, sorry. We take care of the symptoms. So people will have pain, fever, diarrhea, nausea, all those will be taken care of. Oxygen supplementation comes in for those who are having difficulty in breathing, those who are having, sorry, excuse me. I think my throat is still waking up. So the mechanical ventilation is given for those who cannot breathe on their own. But this assumes that the person's lungs are still able to take in oxygen if given oxygen. We sometimes, I don't think this is in Kenya yet, maybe it is, I don't know, need to do extracorporeal oxygenation, where you basically take the blood out of the person, pass it through a machine that will oxygenate it and take it back. This occurs where the person's lungs are totally out, and even if you gave them oxygen using a ventilator, it wouldn't help. So there are other complications that you may have heard of, including clotting, where people, especially in critical care, require to be given anti-clotting factors and all that, as well as steroids for severe disease. And if people have, say, kidney failure or heart failure, they get specific treatment for that because we know that COVID can cause those things. There has also been a lot of talk about experimental medications, and I would like to give my view on this. We do not yet have a clear-cut treatment or definitive treatment, what we call, like, for example, if you have malaria, we know you go for this drug or this other drug. So for COVID, people have been trying out several medications to see which ones work. And there is an antiviral called remdesivir. There is another one I've not put. There are several antivirals. This is just one of them, like a placeholder, that have been tried. There's also hydroxychloroquine, which is related to the malaria drug chloroquine that fell out of favor a few years ago because of resistance in malaria, but it's quite cheap and is still used for rheumatoid arthritis and other conditions. There is also ivermectin, which is used to treat worms and a few other conditions. And monoclonal antibodies. Monoclonal antibodies, high-tech drugs, are quite expensive, and the current one, the one that is at the forefront that is showing actually that it works for severe cases, is one that is against interleukin-6, which is basically something or a site or chemical in the body that promotes inflammation. So basically, this is a monoclonal antibody to reduce inflammation. You can also have inflammation is what causes so many symptoms in the body, because a lot of tissue are destroyed by the immune cells that are trying to clear the virus. There are also monoclonal antibodies that you can produce by that target specific variants. So for example, if you take a patient who survived from this variant, they could be expressing antibodies that helped that patient clear that variant. And by picking that blood, you can express the antibodies and promote and use them for treatment. So that works, but the problem is that it's limited to that specific variant. It may or may not have activity against other variants. So for that reason, some people go for convalescent serum, which is basically serum that has come from somebody who has recovered from COVID. It tends to have wider reach across different viruses. But the problem is that all these have been tested, and other than the interleukin-6 antibody, the others haven't shown clear benefit. So we have some studies showing benefit, we have some studies showing no benefit at all, and some even showing harm. So the scientific consensus is that these drugs do not have a clear benefit, and so have been left to currently for use only in compassionate grounds where a physician wants to try them, but they cannot necessarily be given as a general guideline, because none of these have been shown to have that clear benefit that you would expect from a drug that you can call a treatment for this virus. And this is where work is still ongoing. There are many clinical trials testing this still in different combinations, including with azithromycin. I remember looking at some data last week that was saying when you combine azithromycin and chloroquine, in fact, in that study, some people were at higher risk of death. So it is still an open area. We cannot say that these drugs cannot be used because they're licensed. They can be used for other reasons. So when a clinician feels that they can try them on their patient and they have weighed the benefits and the risks, using their knowledge as a clinician, they're allowed to use them compassionately. But this cannot be given as a general guideline because there is no clear benefit yet. The evidence or the scientific consensus, looking at the properly designed studies, is what supports that decision. I want to say designing studies properly is important, because when you publish, say I have treated 50 people with one drug, and those 50 people, all of them survived. Does that mean the drug works? Not necessarily, because maybe even if I had not done anything, those 50 would have survived, even if there were 100. So if you do not design a study properly to look at the random effects, to look at a comparison group, to look at what we call confounders or other factors that can influence the outcome, then you end up making conclusions that are not valid. And we're seeing a lot of that in the media and also in medical circles, where people pick a study that is not properly designed for the conclusions that they're making, and then use that as evidence that their conclusions are true. So that is something we could discuss further. So what about variants? Now, we should remember that all viruses change over time due to errors which they make while making their copies. When a virus infects a human cell, it makes millions of copies. In the process, there will be errors. This occurs more frequently in some viruses as compared to others. For example, HIV is notorious for making these errors. That's why we haven't had yet a vaccine that works for it, because you make a vaccine for one variant, the same day another variant is there, and it's totally different from what you made the previous one. And most errors are usually insignificant. They do not give the virus any benefit. They do not give it any should I say, disadvantage. But once in a while, you get mutations that will make the virus less fit. It may die off, or it will give the virus an ability to survive and be more dangerous. And this is what makes what we call variants of concern. You may have heard of variants of concern. And the reason we're worried about some of the new variants is their impact on infectiousness. We've had some variants that have been shown to be able to spread faster. And this is because of the ability of, when they change the part of the virus that attaches to the host, to the human cells. And that part, after changing, is able to attach much more easily and much more strongly, making it easier for the virus to enter the body. So that is one of the things that impacts infectiousness. The other thing is the ability of that virus to have a very high viral load, basically to make very many copies. That means it's multiplying very efficiently. And so when somebody gets infected, their throat area, their upper airways are infested with high doses of the virus. So every time they sneeze or they cough, they end up seeding a lot of virus in the environment and those close to them. You end up having more people getting infected. So these are the things that impact infectiousness. And we've seen that they vary from variant to variant, although there are still questions on how big the impact is. The other thing that we worry about when we are talking about variants of concern is the disease severity. There have been actually a report recently of one of the viruses that is thought to cause more severe disease, but this is not very clear. So we're still looking at all the data available to see if indeed any variant causes severe disease. So far, most of the variants have been causing the same kind of disease as the previous ones. What about impact on existing immune response? This is where the vaccines fall. This is where pre-infections fall. So what happens is that when you get infected with one variant, say in March last year, you get antibodies. We do not know how long those antibodies last yet. For some people, not so long. For others, they seem to last a bit longer. So what happens when you get exposed or infected with a different variant? Does that cause disease in you or does it not? So those are questions we're still worried about, that maybe some of the variants are able to evade existing immunity, again, by changing the surface structure, by changing what the body recognizes and attacks. So if the antibodies were made for a specific shape and that shape is changed, the next time that changed virus enters the body, it may get a chance to multiply before the body can neutralize it. And that way, it may even cause disease. So that is one of the questions we have with variants of concern. And again, not very many variants have been shown to have this ability, but a few have been shown to have at least partial ability to evade the existing immune response. Whether this grows in future to complete new strains or new variants that are no longer responding, whether this grows in the future into new variants that are no longer responding to the existing immunity is something we still need to keep monitoring so that we know for sure what we need to do. There are options if that happens. We do that with influenza. We know that every year there are new variants that come in or strains that come in that we have to change the vaccine for. That can still be done for COVID. What about impact on public health interventions? Does it mean because there are new variants, we need to change the prevention measures? On the large part, no, because all these variants are transmitted in the same way, through touching surfaces that are contaminated, inhaling droplets that contain the virus. And so, although if there's one that is more infectious and spreading much faster, it may mean much more stronger social distancing rules, like more lockdowns in some places. It does not necessarily mean you need to change as an individual what you've been doing to prevent the disease, because you need to keep washing hands, you need to keep social distancing, you need to keep your mask on at all times. So those are the concerns. As I said, there are hundreds of thousands of variants, and this keeps increasing every day. In fact, I think the UK, which has been sequencing so much, sequencing is an analysis of the full genome of the viruses to check on these mutations. So UK has sequenced hundreds of thousands of viruses as compared to Kenya, which has sequenced 686. So because of that, they've discovered 115,000 variants. But you see, we only hear of one or two. So I'm just going to mention three, which have been probably the most discussed, but you should know that there are hundreds of thousands of variants. It's just that only a few are discussed because they are the ones we call variants of concern. There are a few others that we could add on this list, but the top three are 501 YV1 or variant 1, variant 2, and variant 3. Now, just for literacy purposes, 500 is a position allocation of a certain on the genetic makeup of this virus, on the spike protein, where one amino acid is changed for the other. So this is really the essence of describing this 501Y. And the versions have other mutations. So all of them share this common mutation, but they have other mutations in their genetic makeup that make them different. Say version 1 is different from version 2 and version 3 because of those other sets of mutations. The V1 was detected in UK in 2020, November, but it had actually been in circulation since September and now has taken the dominant position. And that is what suggests that it's more infectious. There was also another strain that was first detected in South Africa in December, and another one detected in Japan late last year, but in travelers from Brazil, and then looking back, they realized it's been in circulation since June. So these are the ones that are causing a bit of concern because they have one or two of the features that we mentioned before. And some of them seem to be escaping the existing immunity and the ability to spread faster because they have dominated the scene where they occur. In Kenya, we've actually had at least out of the 115,000, we have only sequenced 686. Unfortunately, that's a very small number. I think we should have sequenced around 10,000, but it's a costly affair. So it needs funding. And I was happy when I saw the president recently ask the Ministry of Health to actually invest in this. So I'm hoping we see a lot more of that. But out of the 600 that we have sequenced so far, we have one of the UK variant, the variant first detected in the UK, and we have 6 of the V2 variant detected in South Africa. And that is just because we've sequenced 600. What if we had sequenced 10,000? We don't know how many more variants we would have. Now, out of the 686 variants we've sequenced, we have already all the 8 groups. Out of the 8 groups that are possible in the world, I think we have 7. And these are the clades. Clades are different groups of the viruses. And you can see most of the viruses are in this major group, but there are other groups here that are also having viruses in the country. This means that we have a very diverse picture showing that our infections have come from different parts of the world, and also most likely when it got into the country, it got a chance to multiply and even made its own strains or variants. So it's a very diverse picture that with 600 isolates or 600 sequences, we cannot fully understand. So that is a gap we need to fill. We cannot say for sure which variants are circulating in the country, what impact they're having on our transmission patterns, what impact they're having on our outcomes in terms of whether patient dies or lives, or on the reinfection. Are they able to avoid existing immunity and cause infections? We cannot say that because we do not have enough data to go by. And you can see already we have so much variability. If I went into the specific lineages or strains or mutations, they are in the hundreds. Out of these 696, we have over 100 variants, so to speak. So that means we need to sequence more so that we get more data, and this will allow us to analyze our own situation, and especially now that we've started vaccinating, to be able to follow up and see how well the vaccine is working against these variants, and whether there is any variant that is likely to be of trouble, so that when we detect it, we can quickly move in and isolate and even do cluster tracking if that is still possible. So that is the situation of variants in Kenya. In terms of vaccines, so far, if you look at all countries, including China, Russia, UAE, South America, We have about 12 approved vaccines, and these have been approved either for use, complete use, or for emergency authorization use. We also have another 82 vaccines in clinical development and 182 in preclinical development. So this is still ongoing. We still hope that this technology will be available to us as because fighting COVID is going to take years. It's not going to be.
Hello, Doc.
Yes.
1 minute, if I just want to put across one. Lorna is my name. Before we go to vaccines,
yes,
there are quite a number of questions that I'll just like you maybe mention as we proceed on the variant part before to the vaccine. So one that I have here is the new variant of COVID-19. Does it affect children? And do we have any cases reported for kids in Kenya? I think before the slide of vaccine, if you can maybe mention on that.
Yes, the new variants can affect anybody. No one is immune to them. So long, unless you've been infected before or you've been vaccinated, then you may have some immunity to most of them. But as I said, in Kenya, we have only sequenced, we've only analyzed 600, okay, let's say 700 samples. So out of the 115,000, so we cannot answer some of these questions definitively, like how many children have been infected with this or the other variant, because we've only sequenced so few. That is a gap. But yes, these variants can infect anyone. They can infect children, adults, so long as this person is not immune. And immunity is most likely from the vaccine or, in some instances, previous infection. I don't know if that answers your question. And thanks for interrupting. I was beginning to get bored of my own voice.
Yeah, there are quite a number of them. So if I say something, maybe the team has posted, I shall interject.
Yes. So I will move on, and then we'll also come to the chat and probably discuss these questions. Now, for vaccines, as I was saying, there are many of them being tested. The ones that I would call the front runners. This is my own list, so it could be biased, but I think I picked the ones that I thought were front runners. We have, of course, the Oxford AstraZeneca, which has now 82% efficacy, meaning if you immunize 10 people, 8 of them will actually be protected. It doesn't mean you have 82% protection. And the storage is 2 to 8 or in a fridge. There are others like Pfizer and Moderna that have higher efficacy, but storing them is a bit difficult for countries like ours because we've decided to be poor for our generation. And we have others that you may not have heard much about, like the Sputnik V from Russia, which is actually quite efficacious. And an interesting collaboration now is between AstraZeneca team and Sputnik to come up with an arrangement that allows you to get one vaccine, say Oxford at the baseline, and get a Sputnik booster after maybe 6 weeks or 8 weeks to ensure the vaccine works better. So this has not yet been released. It's still being tested. And if it shows to work, then I think it will be a good arrangement, mainly because of the collaboration, because it's very difficult to see mainstream European companies collaborate with Russians. So we know when collaborations occur, then you have more efficient systems, much better resource capacity to make a good thing. The other one that you may not have heard about is Sinopharm, which is based in China, and Covaxin, based in India. There's Johnson & Johnson, which I found interesting as a one dose, because you only give it once. And this is actually the one being used in South Africa. So I will talk briefly about the types. The viral vector is what we have as AstraZeneca, meaning that we modify a virus, like in this case, it's an adenovirus, a chimpanzee adenovirus that was modified. Adenoviruses generally cause common colds, generally, so they don't have a lot of problems, but they are modified to make sure that they do not cause disease in humans. They are not able to replicate or make copies. And after that, the part of a genetic code for the part of the COVID virus is inserted in this virus, this vector, the adenovirus vector. And when this adenovirus vector is injected into the body, it will enter the cell and produce the protein that is part of COVID virus. And by producing that protein, the body will recognize that protein as an antigen or as an immunogen or as a foreign body, and it will produce antibodies against it. And by producing antibody against it and eliciting also other immune responses that allow you to remember similar infections, it means in future, if you are exposed to something that it looks like it, which now will be COVID-19, then the body can clear it. So the vaccine does not cause disease in humans, but it may cause side effects. So that's not equivalent to disease, because when I mean disease, I'm talking about the COVID disease. It will not cause COVID, but it may cause some side effects which are acceptable. They are not, none of them are severe. The messenger RNA works in a similar way, but now instead of using a vector to deliver it, you just use what we call small fat particles. Our cells easily take up fat particles because the cell covering is made up of these lipids. So because of that, you enhance the entry of the vaccine into the cell. The cell is able to produce the, again, part of the virus, the part, a protein that is similar to part of the virus that is then able to elicit or make the body produce antibodies. So really vaccines train our bodies to make antibodies or to make an immune response against a pathogen by using something similar to that pathogen, so that in future, if you're exposed to the bug, then you're able to protect yourself. The inactivated forms are really just picking a sequence from the virus, using that sequence to express part of the virus. And the expression means you use like a factory basically to make proteins that looks like what is produced by the virus. And so again, that is injected, purified and injected to you so that your body is sort of trained again to produce antibodies against part of the virus. And when the virus comes, those antibodies can neutralize it. Really, that's the gist of it. The other thing that is important is storage. You can see the ones that require refrigeration are much more likely to be adopted in Kenya than the ones that require freezing. I know there's a lot we can discuss here, so I will just wait for the questions. The other thing I would like to highlight is how vaccines help. Now, the main thing is that vaccines will help us from reduce the risk of getting sick. So those 8 out of 10 people who get the vaccine, even if they got infected, they will not get sick. What do I mean by getting infected? If I have COVID and I cough next to somebody who has been immunized, the virus can still go into their nose, it can still go to their throat, it will try to multiply, but it will be controlled by the antibodies. So even if they got infected, the multiplication or the copies being made in the throat are much fewer, so they are not able to cause disease. Are they able to infect another person? Maybe, we don't know. Current data suggests otherwise, but we are still not 100% sure. That's why we are saying, even after being immunized, you still need to wear your mask until we are sure that most people have been vaccinated so that no one is at risk of infecting the other. The other thing that is important is to reduce the need for hospitalization, so that even if somebody got sick, they do not need hospitalization. You have mild symptoms that do not require hospitalization. This releases hospital facilities, it releases the pressure on healthcare workers, and also, of course, your own time to do other things. And of course, reducing deaths, which is what ultimately we want to do. Whether it reduces transmission, a lot of the current data suggests strongly that it does, but we still don't want to declare that as a fact until we have all the evidence that yes, this is true. And that is, again, based on the evidence we have. We will also be able to reopen sooner if more people are immunized. For example, in countries that have immunized, like Israel has immunized, like 50% of their population have received at least 2 doses. So it means those who have been immunized, in some instances, will now be allowed to get together or even engage in activities that may not necessarily put others at risk of not being immunized. But with time, if everybody or if a majority of the world is immunized, then all of us can do that. We can be able to travel much more easily with less trouble having to get tested and all this, and also have economies running back to normal. We are losing billions, of course, in economic losses every day to the COVID-19. So the cost of the vaccine is much lower compared to the economic cost that we are suffering every day. The other thing I'd like to highlight is this, that if you look at the number of doses given by yesterday, or 16th March, and this is information I collected from Bloomberg magazine, we can see that over 390 million shots have been given. This is to about 200 million people across the world. And you can see Africa is totally underrepresented, because so far the only country that is doing very well in Africa is Morocco, has immunized quite a number of people. The rest of us I think South Africa is about 600,000. Kenya, by now, maybe 10, 20, maximum 15,000. But we are getting there. We started late. The countries that started in December, they've been doing this for a while, and I hope we'll catch up with time. I'm assuming that ongoing global solidarity will stay, and we can see more vaccines being manufactured, and we see more people getting immunized with time. And you can see across 128 countries that have already started. So most of the countries that are not immunizing are mainly in Africa. For some reason, maybe because resources, but also I think there has been a perceived low burden in Africa. So the urgency was not so much in most countries that would have wanted to get this. So these are quite a number of doses. And for the side effects that we are hearing, if there was really a big risk with the vaccine, 390 million shots given would have had so many problems reported. And we know that is not the case. It is hard to hide that in the current world. The challenges we have, of course, is that the need is far greater than supply. We need 7.5 billion times 2 for most of the vaccines. That is 15 billion doses. That is far greater than we can manufacture in a year or two, unless we do something out of the norm. Distribution is also a challenge. Imagine getting the vaccine to Nairobi and it has to get to Lodwar or elsewhere. And also imagine getting the vaccine from wherever it was manufactured, say in India or wherever, to other parts of the world. So that distribution takes time, it takes money. Misinformation is a real thing. And that's why I was happy to share my views with you, because I'm hoping that I'm sharing correct information or the scientific consensus, not just my views. But there is a lot of misinformation in social media. Most of it is based on things that are started as a joke, but others are started with an intention to misinform, actually, or a genuine misunderstanding of facts. So what I usually do is engage such misinformation factually, find out whether what they're reporting is correct or whether what they're reporting happened, and then try and engage and understand why it happened, where it happened, how it happened. And by doing that, you may be able to correct wrong information that is circulating. Vaccine hesitancy is a real thing. We have people who naturally do not like to take vaccines, so they'll refuse all vaccines, and your people will accept all vaccines. That is given in any population. The numbers vary from vaccine to vaccine. For some, it will be like in Kenya right now, we are suspecting it may be a quarter of people may be in this category and this category where they delay or refuse, so 30%. But with time, I guess if they get more information, some of these who are saying delay may move into accept. But those who refuse may not change at all. But that luckily is a smaller proportion. So vaccine hesitancy is real. It is informed by many things, many of them historical. There's also, of course, a global anti-vaccination campaign that has been running for a while for one reason or the other. So we have a lot of challenges with this, and the only way to combat it is by giving people the right information and giving them the free will to choose what they want to do with their bodies. So if they want to get the vaccine, if they don't want to get the vaccine, we do not want to force them. Other than that, I would like to propose that we keep our standard prevention strategies. We now know them, all of us. We promote vaccine uptake. If we get the chance to take it, let's take it. I know we are doing this in phases, so maybe some of us will get it faster than others. I got mine about 10 days ago. I didn't experience any side effects, but I know some of my colleagues did, maybe fever, joint pains, muscle pains, fatigue. Some even had to miss work for a day. But the risk, the discomfort of those side effects is much less than the risk of getting infected with COVID-19. I expect my dose in early May, my second dose in early May. Maybe I will experience some side effects then, I do not know, but I'll still take the vaccine because I know it will benefit me. There are also, there's need for us to keep acquiring the right information and sharing the right information. If you find a story that is too sweet to share, then you need to check if it is right before you share it. And then as a country, we need to gather more data on the vaccine and the viruses. So right now, I know, for example, Kenyatta National Hospital, for the people it's vaccinating, it has designed a document where online where people can report side effects and monitor how many people actually report side effects, how many they are, and that gives us an opportunity to follow up if there's any issue with the side effects. And we also need to find out what variants are circulating. Are they being controlled by the vaccine, or are they totally new? Maybe we have our own variants that we do not know, but we cannot say that for sure unless we look at what is circulating more keenly. So thank you very much. I hope I wasn't too fast, but I'm happy that we've spared about 10 minutes for questions.
Thank you. Thank you so much, Daktari. That it was very, very, very educative. We believe most of us and all of us have come up with something. I realize we're running short of time, but I would like to spare some time. We have vast of questions. I would like to encourage our listeners that our lines, our contact lines for APA insurance are open in case we'll not be able to answer your question. You can share it with us on our email and we'll send it to Daktari, who will be able to, very happy to respond to you. Our email address is cdm.wellness. I repeat, cdm.wellness@apainsurance.org. That is lowercase. Our numbers, you can always get us on 070 99 12 888. So without much waste of your time, Daktari, I appreciate you so much, and I believe so is my team. I would like to usher in my team who will take us through the Q&A. I have Lorna Oside, and I have Justus online who will maybe assist you, Daktari. Just before I go off, I would like to just pose a question that somebody posed maybe, and it confuses a lot of people between normal chest pain. You know, we have different types of chest pain. And one of our first participants asked, do you want to clarify a bit on what you mean by chest pain? What are they, what type of chest pain are you talking about when it comes to COVID?
Yes, thank you very much. Chest pain can come in many forms. As you say, there's a tightness, there's some pressure, but one of the best things you can do is, for example, if you have something happening, either a pneumonia thing happening in your lungs, is when you take a deep breath, you feel that pain, and it almost prevents you from breathing. That means you could have pneumonia either by a virus or a bacteria or whatever sort. I think that is the easiest way. And that's why, as your own person, you may not be able to determine what it is unless you're a trained clinician. Even if you are, you need to be assessed by a professional. Sometimes they need to do imaging like a chest x-ray or something just to confirm what is happening. Sometimes many of the pains you experience on the chest are mechanical. Maybe you slept on something that hurt you, or you lay in the same position in the wrong position for too long. Those are usually muscle pains on the chest wall. But if it's a deep pain in the lungs, when you take a deep breath, you feel that sharp pain. And sometimes also when you're breathing, you may feel some pressure around your chest that doesn't allow you to breathe very well.
Thank you. Thank you so much, Daktari. And over to you, Lorna.
How about seeing everywhere reports about new symptoms and knowledge about the surge in infection, especially in the beginning of the third wave? Is it likely to cause mass hysteria among the public?
Yes, the misinformation can cause panic, but that's why we counter misinformation with information. I actually purposely put the symptom slide on this presentation just to show you that the symptoms are the same. The frequency has differed. So some are more common, some are less common, but they are the same symptoms the previous strains were causing. But yes, misinformation can be a cause for panic. If you mismanage information, it may also cause panic. But I don't think the new variants are causing any different illness. It's causing the same illness. The question is whether they're able to spread faster or even evade existing immunity.
Thank you, Doc. Another question, I'll combine them about, you elaborate more about the children and the immune. One question we have is we have noticed less cases of children affected by COVID. What could be protecting them? And then there was another question that has also been raised about pregnancy and the unborn child, about either contracting the virus or not, and then the management of that, if you can combine the two.
Okay, thank you. So we do not have, children can be infected. The only thing is that because of the activities they are doing, they may be at less risk compared to adults, especially when they were not going to school. Now that they're in school, if there's an outbreak within a school, they can be infected just like any other person. The good thing is that the children do not have as many, are not likely to have severe symptoms as adults. Many of them will be asymptomatic. So they are not likely to go to hospital. They're not likely to report any symptoms. They're not likely to be tested. unless there's an outbreak within a school or within an enclosure where children are. So for that reason, we tend to underreport their infections a lot, but also because they're not at risk of severe disease, so we're not too worried about them. Now, in terms of pregnancy, we know that the pregnant women can get infected. Some of them do get severe disease. There is a school of thought that thinks that pregnancy could be a risk for severe disease, but that is not very strong evidence for that. But what we worry about is if they do get severe disease, then what is at risk is that they may actually end up having to deliver the child early, and so we could end up with a premature birth. There is no evidence so far that the virus can cross into the child during pregnancy, and even in breast milk, there's not evidence for that. But we are worried if a woman gets severe disease and she's pregnant, just like any other person who gets severe disease, could get complications. The woman who gets severe disease may end up having to deliver the child prematurely. But for most of them, they'll end up with mild disease and still that does not necessarily affect the body. I hope that answers your question.
Yes, it does. To many of us who have raised that question, I believe it has answered most of us. I'll ask another question that has been posted here. I think the vaccination was tested of specific strains. Does it mean the vaccination will not be as effective against the third wave or upcoming waves?
We currently do not have sufficient reason to suspect that the third wave is based on a different strain or variant. We do not know that. I think for me, we've seen what has happened over the last few weeks, opening schools, but mainly political gatherings, which are super spreader events, because you carry people from one end of the country to the other part, and that is a problem. So I do not want to link that to variants because I don't have any evidence for it. Now, whether the vaccine works for all new variants is a question that remains to be answered. I think it will work for the current variants, at least partially for most of them. There was a study in South Africa that showed partial protection, very little protection, maybe 10% against mild disease of the South African variant, if I can call it that. It's not the right way to call it though. But across most of the other variants, the vaccine didn't have problems. So it calls for more data to be collected. But in my view, I think there will be partial protection. And in any case, we are likely to reduce severe disease from any of the variants at this point. Whether in future that is the case, we can only answer that question if we continue collecting data. I think right now, not giving the vaccine is much worse than giving it, because when you give it, you at very worst get partial protection of the population. That is, even if you get 80% or 60% of the population protected, that is enough to control at least the speed of the spread. Next.
Thank you, Doc. We are really getting educated. The next question that is quite interesting, and I know maybe you've touched on it. What happens when you get the first dose and fail to get the second dose? I think what we are getting in 2 doses. So that is a question that has come through.
Yes, that's actually a very good question. It's a scientific question as well, because the UK has tried to do that. They have, I think, immunized 24 million people with dose 1 and maybe just 2 million with dose 2. And what they're trying to see is if the protection you get from dose 1 is sufficient to control the pandemic. We know, at least from AstraZeneca, the first dose will protect about 75% of, about 2/3, 70% of the people who get the dose. So it is not as good as getting both doses, but it's better than nothing. So I would encourage people to get both doses, but even those who get 1 dose are better off than those who get none. And even for the population, you get some partial protection by giving some people 1 dose. The only question is that, does this impact the transmission patterns? And this is a question as a population, that is, does it affect the population? Does it help control the virus? Because if you are only giving each person 1 dose, you will cover more people quickly than covering a few people with 2 doses. So I think for now, I would still stick with the 2 doses, but even those who get 1 dose are better off than those who get none.
Thank you on that. Another interesting question is, What are some of the early intervention measures you can give to patients with underlying conditions? This includes the diabetes to improve their outcome when they get. And this underlying condition, Doc, you can also mention the HIV part, the cancer cases on the early intervention.
Okay, so underlying conditions that have been shown to increase the risk of severe disease, and this does not mean everybody with diabetes or everybody with cancer who gets COVID will die. No, it is maybe about higher than the normal population, but it means they have to be taken care of much more closely. The underlying conditions will include conditions that affect the heart, affect the lungs, like asthma, heart failure, cause cancer, and hypertension, obesity, diabetes, and what have you. HIV, on people with who have HIV but they are controlled, they are on antiviral agents, they are doing well, they are not at any greater risk than the general public. We've not seen any, so far there's not been any evidence suggesting that. What we know is that if somebody is HIV positive or immunosuppressed for any other condition, maybe the immune system has been weakened by drugs they're using for other conditions, then that person is the one who is at greater risk. If they're HIV positive, their immune system is weak and they're not on treatment. So that could be maybe a risk for severe disease. And so what we need to do for such people is first, they need to be able to access the hospital quickly. That means you need to be hospitalized or near a hospital. You can't be too far. And you need to be monitored closely, looking at your oxygen levels, looking at your general outlook. Are you having any problems breathing? And because they're isolated, they need to resist the temptation to stay in bed throughout because they could get clots. So this is meaning that they need to take walks either in open spaces where in a mask, of course, or within even the room where they are, just walking and sitting up rather than lying in bed throughout. Because if you do lie in bed throughout, then you may have worse outcomes because of the clotting and whatnot. So I would say the closest thing they can do is monitoring. They be in touch with their doctor if they have one, because most of these people are chronic conditions are in touch with their carers, but also be able to access a hospital quickly. For example, they notice the oxygen is dropping with the oximeter, they can get to hospital quickly if they are not in hospital already. Thank you.
Thank you, Doc. I have a request to put on that. So another question that I've seen most people asking is it true that when your white blood cells counts go down, you could be positive of COVID?
Now, there are many things that cause a drop in white blood cells. Yes, COVID or any other virus is one of them, but you can't really look at one lab test and say this person has COVID unless that lab test is the PCR test for COVID. So I would say white blood cell drop is one of the symptoms, but I mean, one of the lab markers, but it's not the most reliable. You can't just, oh, this guy has a drop in white blood cells, this must be COVID. No, that would be wrong.
Yes. I'll allow Justus to ask 2 more questions on the chat as we proceed. Justus? Sure.
Yeah. If somebody's talking, I can't hear.
Yes, I think just as microphone is muted still. So let me proceed on that. So the question that is here again, I have seen several people having sore throat and some even losing their voices for a day or so. Is this a symptom of COVID? Then on top of that, Doc, also there is a question on the loss of smell. How long shall that should we expect to have it? So as you talk about, maybe you can just wrap it again on those symptoms, the cardinal symptoms.
Okay, so thank you. I'll start with the first one, that having a sore throat and my voice disappearing. My voice was disappearing today. I don't think I have COVID, although I can't tell. So what you do is assume you have COVID, whether you have symptoms or not, unless you're tested. And that's why you need to keep your mask on all times, stay away from people. And I assume everybody else has the same, even those who have been immunized, until we know for sure that their immune systems are working, because vaccines will take weeks to create enough antibodies in the body. So do not assume that a person who has one symptom has COVID, just assume everybody has COVID. If the symptoms get worse, they can get tested. But it's difficult to say because somebody has a sore throat or somebody has a common cold that they have COVID, unless you get a lab test. You can't look at somebody and say this is COVID. It has to be confirmed with a lab test. The other question on loss of smell, that actually occur, and some people will spend months. I've seen somebody 6 months and they still haven't gotten it back. But in most instances, it will come back within a month or two. So it's one of those things that I think we'll still need to follow up and see how long it lasts and whether it can be permanent. We are not sure. But for most people, it returns within a month or two.
Asante Daktari. What guidance will you give to pregnant and breastfeeding mothers regarding taking the vaccine, considering that children are not getting the vaccine? I think that is concern of most of us and
yes.
New mothers.
It's a good concern, and I'll say this. We have not tested this vaccine in enough pregnant women to know whether it is safe or not. We do not have any evidence to say that it is safe in women. But looking at the data we have so far, we can say that if this pregnant woman is in danger of getting infected, they should take the vaccine. If they are maybe working in a health setting where you are at high risk of getting infected, then you're better off with the vaccine than without. This is because of the design of the vaccine. We don't expect it to affect the fetus. There have been some animal studies that didn't show any effect on the fetus, but because we do not have any safety data on the women, on pregnant women in general, people who are not working in places where that high risk, people who are not in the healthcare settings who are out there, do not necessarily need to take the vaccine. They will not be denied if they get the chance to, but we do not recommend it for them. But I would say if you're a healthcare worker, you're at risk of infection and you're pregnant, I think it is a good call to take the vaccine. The only thing I would like to say is that right now we do not have enough evidence to show us that it is safe in women who are pregnant or to show that it is harmful. And this is because when you're testing a new product in medicine, you do not take it to the weakest or to the vulnerable. And in this case, the fetus is vulnerable. And so we do not test on that until it has been completely done in children. So now the current clinical trials are going on in children. And then after that, they can be taken to pregnant women. And also data is being collected from those pregnant women who opt to take the vaccine, and we see if there are any effects. So for now, there's not enough data. The person is at will to decide whether to take it or not. The other thing on breastfeeding women is the vaccine can be given to breastfeeding women. I think it is not going to do any harm to the baby. Although again, I don't think we have collected enough evidence to see if breastfeeding women will harm their children. But my judgment is that it will not.
Very, very educated, Daktari. I believe we are all learning and we are happy on this, what is coming up. Another question that is here, Daktari, there is also posts circulating on social media that indicates that the new variant is no longer showing when a swab is done on the nose or throat, and that it is hiding in the lungs. How true is this?
Now, one of the concerns I should have highlighted is that sometimes we worry about variants of concern being able to avoid existing diagnostic measures, especially PCR, because if they mutate parts, PCR looks at a part of the virus genome. So if that part is mutated, it may not be detected. Luckily, the PCR tests we are using are looking at 3 parts of that virus. It's unlikely that one virus will delete all those 3 parts. So for most variants, we've been able to detect them with PCR. We have not changed our testing, and you can see the cases are going up. So if there was a new variant, it is still being detected because we see the cases going up. It is a concern that we need to keep in mind, and we keep looking at it. It's an analysis that looks at the frequency of these changes, and the numbers are still very low in terms of the changes that occur in these areas that are targeted by the PCR. And it's unlikely that a virus will be able to avoid all 3. So for now, it's not our biggest worry. It is a concern, but I don't think it is happening in most of the instances. If it happens, it's very few cases. Most of the time when you get a false negative test, meaning the person has COVID and they were not tested positive, it's possibly an error when you're collecting the sample. You do not get enough sample, or sometimes in the analysis.
Thank you, Doc. I want to ask the last question on our Q&A section, and I'll combine the one question into three. Is it possible to get reinfected up to 4 times? Does one develop some level of immunity after they get into the first time? So that one is one, Doc. I just want you to combine with this one, which go one in one or hand in hand. If someone has COVID and he or she is asymptomatic, can she get the vaccine? And then this one, what if someone gets infected after the first vaccination and before he or she gets the second dose?
Okay, so these are very scientific questions. They're questions we should be asking ourselves in the lab, and we are asking ourselves. One is reinfection. You can get reinfected, we know. How many times, we do not know. What we know is that there are people, especially those who are symptomatic, the antibodies are not very strong. They do not last long for some of them. So it's possible to get infected. Whether they get infected more times, we can't tell, because I don't think we looked at the virus long enough to see people getting reinfected 4 times. There may be people who express the virus for long periods, some for months. And some people may think that is reinfection, but I think it's possible to get reinfected, not for everybody, but for a few people, and especially if the immunity that was acquired did not last for too long, for one reason or the other. Asymptomatic COVID-19, if you have not been tested and you don't know, you can take the vaccine if you're asymptomatic. But if you know you have COVID-19, you should wait at least for about 14 days so that you know that you have no symptoms, because you could get immunized today and then you develop symptoms. You don't know if it's the vaccine or it's the virus, because the fact that you're symptomatic today does not mean you will remain asymptomatic until the illness is over. So we say if you do not have any symptoms, you can get immunized. But if you have symptoms or you've been tested and positive for COVID-19, you can wait for about 14 days before you get immunized. Infection after the first dose and before the second dose is possible, because as you said, I got my first dose on 10 days ago, maybe I formed a few antibodies, I don't know. So if I haven't formed any antibodies and I get exposed, I could get infected. Maybe I will find out I was infected, maybe I'll find out, maybe I will not find out. I will still get my second dose. So what I suspect is that people who get infections from COVID may have a little more side effects from the virus, because the immune system has already been exposed and is going to have a more robust response. So from that immune response, they get more side effects. But I think it's still worth it. There's still a question as to whether people who have been infected it would be enough to get 1 dose or just 2 doses. We don't know that answer yet. So we cannot say for sure the answer until we get it. But I would say even if you've been infected before, whether between the doses or before the doses, you can still get your doses. So long as there's enough time between the time you showed symptoms or you got sick and the time you get, and that would be 14 days.
Okay, Daktari, I said that was my last question, but one has struck me, and I think all of us will want to learn or hear this, because I know most of them we will share. How true is it that dawa concoction of lemon, ginger, honey, etc. work against the COVID virus? I think this one I wouldn't have left it.
Yeah. The dawa concoction is one of my favorite drinks every time I go to places that are serving drinks. But it's not a dawa for COVID. It's a good drink. It's healthy. You can take it. Of course, if it hasn't too much sugar, we know has issues. But it is not a dawa. It's not medicine for COVID. It has no benefit in terms of killing COVID. But I mean, it could have some nutritional value, because you're getting in fruits and maybe some micronutrients. But you can't use that as a way of preventing COVID. If it makes you drink more water, please do. I mean, I put stuff in my water like my water I'm taking today has a tea bag. Maybe another time it will be a slice of lemon or something else. So some people find it easier to take water when it's in that form than just clean, pure water. So that is okay. It doesn't harm you to take it if you can find it, but don't tout it as a treatment for COVID. It is not.
Thank you, Daktari. Thank you, team. It has been such a wonderful morning, a wonderful session, a wonderful presentation, knowledgeable, and we've learned. Learning never stops. Every day is a learning day. So Daktari, for sure, the whole of us, the whole team, We appreciate you. We appreciate the presentation. We have really learned. And the question, I can tell you for sure, there are so many questions on our chat box, on our Q&A section. We will share all of them. The team has really responded well, and I can tell you for sure, COVID being a pandemic that everybody is learning, everybody is trying to find better way. People have a lot of questions. So Daktari, if you allow us, we will share all these questions with you so that you'll be able to respond to all that have asked those questions. We shall share with Daktari so that you are able to get the answers to all these questions that are raised. So without going into much detail, the doctor has wrapped it up all and has given us an informative piece of presentation that we are able to use in our day-to-day so that we protect ourselves, we protect our neighbors, and we protect the country and the world at large. So as we wind up, feel free to send us through your questions. Feel free to call us through our lines. Our lines, which are our case management line, the CDM lines, we have 0709 91 2888. You can call us. We are 24-hour. We operate 24 hours. Any questions, any concerns, we will be able to assist. We also have our emails, our care team emails, as well as our CDM emails. So thank you, Daktari. Thank you, team, for joining in. And thank you, everyone, wherever you've logged in. We really, really appreciate, and we really say asanteni sana. As I wind up, I will allow Lucy, the head of case management department, to just have a word. Thank you so much.
Thank you, Lorna. Lucy, I don't know whether you are on. She seems to be a bit held up. It's okay, Daktari, thank you so much. On behalf of my team, our head of the medical division, Mr. Justin Koske, our head of retention, Sheila Gishui, Lucy Kuria, Anne Modhoni, Emily Amayo, Justus and Lorna, and my behalf, we appreciate you so much, Daktari. Karibu sana. We hope to call you again soon. Please do not hesitate to join us. Otherwise, I want to wish everybody on here a lovely day and God bless you.
Thank you. And keep up such sessions. I think information passing is good for us, good for the public, and good for you too, because you may end up cutting costs.
Sure, Daktari.
Thank you.
Thank you so much. Thanks, everybody.